Okay, folks, good morning, good afternoon, good evening. Let's wait a minute or two. So welcome to this prize competition session. Are you able to see my screen here?
Yep.
Yes, wonderful. So for everybody, if you've attended a session before, that's great, but just want to introduce you to our judges. Stephen Harsono, Head of Public Health from IQVIA Asia Pacific. Pascal, she's Vice President for Healthcare Sector at William Davidson Institute here at the University of Michigan. Azuka, who is the CEO of the Africa Resource Center in Nigeria. Kelly, who is Program Officer at Bill and the Gates Foundation. And Sriram Dasu, who is a faculty at the Marshall School of Business, University of Southern California. The way we will do this stuff is each team has 25 minutes to present, followed by Q&A from the judges, and then as time permits, we'll take questions from the audience. You may either put your question in the chat box and we will go from there. So without further ado, our first presentation is by Sara Haider on adaptation of a private sector call center model for availability and visibility. So Sara, over to you. I'll stop sharing. You may share your screen. Let me see, I think. Let me just activate it. Yes, you may be able to, you should be able to share screen now.
Great. Thank you so much, Ravi. And I'll go ahead and just start my video for a moment to introduce myself. So good afternoon, everybody, and thank you all for the opportunity to present. My name is Sara Haider, and I am a program manager at Chemonics International, where I backstop the Global Health Supply Chain Procurement and Supply Management Project, or the GHSC-PSM project, from the home office in Washington, D.C. Since early 2019, I have also been serving as a technical manager for the integrated call center activity, where I work closely with our software developer who is based in Spain on software updates and enhancements, planning for any releases for new enhancements in the system, as well as issue tracking. And I additionally liaise and coordinate between the teams implementing the call center activity across the various GHSC-PSM project countries. While the call center has expanded to several project countries since its initial inception, today's presentation will focus primarily on the call center activity in South Sudan. Unfortunately, our country director for South Sudan is not available to present today. However, I am delighted for the opportunity to introduce this activity to you through our presentation titled Adaptation of a Private Sector Model in South Sudan, the Integrated Call Center. I will share my screen momentarily so that you can see the presentation slides, but I did want to note that while I will be conducting our presentation today, our managing director, Mr. John Stanton, who manages the West Africa and Caribbean portfolio on our project, and who conceived the idea behind the call center activity, is also here today, and he will be joining me to answer your questions during the Q&A session. And hopefully you can all see the presentation now.
Yep, looks good.
Thank you. So during today's presentation, I will provide some background and context regarding South Sudan and its supply chain, the challenge we were faced with regards to health supply chain visibility, as well as the intervention that we implemented on our project, which is the Integrated Call Center, which the project introduced to address these challenges. I will also present to you the system design and information flow of the call center to explain what it is and how it works, as well as provide a brief call center platform demonstration through presenting some screenshots of the application. Finally, I will present the benefits and obstacles of implementing the call center activity, as well as talk about long-term sustainability and what we envision the activity and the call center will look like moving forward. I'll be happy to take your questions along with Mr. John Stanton during the Q&A portion of this segment after the presentation. So I would first like to start by providing some background regarding the context of South Sudan and the in-country supply chain specifically. South Sudan has a population of approximately 11 million people, and as recently as 2018, only 28.2% of the population had access to electricity. In addition, the country has a complex operating environment, which compounds many common supply chain challenges and provides the basis for the lack of health supply chain data visibility in country. The nation's young age and past years of civil conflict have also meant that the country suffers from poor infrastructure, inadequate human resource capacity, safety and security challenges, regional travel limitations, as well as erratic and unpredictable population movement. All of these challenges unfortunately complicate the supply chain and further make it difficult to attempt to retrieve accurate data in country. With regards to the supply chain specifically, there are multiple supply chains which run in parallel in South Sudan and which are funded through multiple donors who have their own priorities. In addition, weak coordination and limited governance characterize the system, and although a logistics management information system, or LMIS, is of course an important element of any supply chain, the poor infrastructure, human resource capacity challenges, and poor accountability mechanisms in country complicate the system's proper functioning. In addition to that, the lack of commodity data visibility at service delivery points and health facilities contributes to recurrent stockout situations and limits the ability to develop accurate distribution plans at the central level. So as a quick background on the setup of the commodity distribution system in South Sudan, I wanted to introduce the figure on the right-hand side of this slide. As you can see from the diagram, commodities are distributed from the central warehouse to service delivery points or facilities across the country. These facilities may include hospitals, county health departments, primary healthcare centers, and primary healthcare units across the country. So now we are faced with our challenge. The previously mentioned complicated country and supply chain context and their adverse effects on supply chain data visibility in country led our project to consider one basic question for intervention, which is how can we increase data visibility of health commodities at service delivery points in South Sudan? The majority of service delivery points have overworked staff and poorly funded facilities. Given the collective limited resources throughout South Sudan, to be successful in our intervention, it was critical for our project to develop a mechanism that did not only rely on electricity access or require complex mechanisms within the facilities themselves. So to address this question, in 2018, the GHSC-PSM project developed the Integrated Call Center, which is an application that utilizes the local cellular phone network coupled with a web-based application to call health facilities directly to capture national stock supply data. The application has the ability to place outgoing calls as well as receive incoming calls, and it includes audio recordings of all calls for quality assurance purposes. It also generates shareable reports of the data that is collected. So in doing so, the call center applies a private sector layer used in many other industries globally to the public health context in a resource limited setting such as South Sudan. The web-based technology and cellular networks that we use in operating the call center are mature, stable, and low-cost technology, and they are also readily available in South Sudan, which helps to ensure that this intervention is not hindered by any of the aforementioned in-country challenges. This technology that we use is also readily customizable and does not require the respondents at the facilities themselves to have any special technological equipment other than a simple mobile phone. And then that, of course, helps to take the burden of specialized technology requirements or equipment away from the facilities themselves and results in greater reach across the country, regardless of each facility's technological capabilities. So instead, the call center is centrally operated by the GHSC-PSM project from the capital of Juba, excuse me, with the use of headsets and computers alone. In developing the call center activity and the call center application, the project worked with local implementers, primarily international non-governmental organizations and clinical partners, to collect contact information from key health facilities across South Sudan. And then that contact information was then coded directly into the application to allow our staff to directly communicate with the facilities. Our call center attendants, who again are based in Juba, use the application to place calls directly to the facilities across the country through this structured web-based portal to gather the stock inventory data for tracer commodities. So how does the integrated call center really work? As you can see from the diagram, the process starts with our call center agents, represented here on the top left-hand side of the slide, who use their computers and local phone network to place outgoing calls to stock managers at the facility level. The stock managers whom we contact may be based in hospitals, county health departments, primary healthcare centers, or primary healthcare units across the country. And once our staff reach the stock managers, the agents start collecting stock on hand and expiry information from the managers regarding specific commodities within specific programs. The stock managers provide this data and our agents enter the data into the call center application in real time using their computers and the web-based portal. When the stock on hand information for each tracer product is collected from each facility, then the data is classified as a completed inventory. These inventories are then consolidated into reports to show facility stock trends over time, and then are also disseminated with local counterparts and stakeholders to help inform distribution and procurement decision making. These facility calls that we do are conducted each month and provide stock trends, as I mentioned earlier, as well as allow us to estimate consumption by comparing delivery information with inventory over time data, and the ability to proactively mitigate commodity stockouts and product expiry issues. So because of a historic lack of communication between the central level and service delivery points in country, the call center helps to provide a deeper level of visibility into individual health facility stock availability in South Sudan. Now I would like to showcase the call center online platform for you. So when logging into the platform, a user is presented with these three icons as you see here. The integrated call center tool, the icon on the far left-hand side of the slide, provides access to the web-based application, which is what is used to place calls to the facilities. It is also used to manage facility information and contact information at each facility. And it is also what we use to generate reports using the data that we collect. The dashboard tool, which is represented here in the center icon, provides statistical data regarding the calls placed, including metrics regarding the number of successful, failed, and busy calls, both collectively as well as specifically by each call center agent. And it also provides metrics regarding the number of inventories collected by date, by user, and by program area. This data helps us to apply a private sector component to the activity by ensuring accountability internally through the ability to monitor the duration and success rates of calls, as well as through monitoring the performance of each call center agent. The help desk tool on the right-hand side is used by the call center agents, their supervisors, as well as the program management units to log any issues or bugs within the application, as well as any requests for enhancements or additional features in the platform that may help to improve the utilization of the application. For our purposes today, I would like to present to you with an example of how the inventory is collected through our integrated call center tool. On this slide, we have provided a screenshot of what an inventory collection page within the call center application looks like. This is the page that our agents use to collect data when placing a call to a facility. As you can see, the inventory page includes data regarding the facility contacted, the agent placing the call, as well as provides a list of tracer commodities, which we are collecting data on. The agents who connect to this facility go down the list of commodities, first asking the stock manager to provide data for each commodity before moving on to the next line. So the agent would first ask whether the commodity in question is typically stocked at the facility in order to ensure that only relevant information is collected. So I'm going to zoom into this portion of the page so you have a little bit better visibility into what it looks like. So then our agents collect information regarding when the internal inventory at the facility was last conducted and what the inventory was last counted. Then the quantity for each commodity on hand is collected. And finally, the expiry information for that commodity is also collected. Once all the fields are filled out, the status column on the right turns green to indicate that all required information has been filled out for that commodity. The agent then moves on to the next item on the list to collect the same type of information. When a stock of 0 is entered for a commodity, the quantity on hand cell is marked in red to indicate a stock out. Additionally, on this page, you will see on the right-hand side of the screen that we also provide the previous stock data for the commodity in question from the last time that a call was placed to this facility. And once the stock information for each commodity on the list is collected, the Finish Inventory button activates, allowing the agent to complete the inventory, which is then saved in the application's database. If for any reason the call cannot be completed, for example, if the stock manager is busy and must step away during the phone call, our application allows the agent to postpone the inventory to another date. The agent can then resume the inventory by placing another call to that facility at a later time or at a later date, at which point the previously collected data from the postponed inventory will automatically populate into the entry form, and the agent can continue collecting any missing information from there. Once the inventory is marked as finished, the completed inventory is presented per this screenshot. As you can see, the data from the previous window, which I was showing, is now presented here in the completed inventory page. Note that any stockouts that were marked in the previous page are also marked in red on the right-hand side column here. Additionally, a full audio recording of the call can also be accessed here for quality assurance purposes. The project ensures that consent is provided for these recordings by providing a disclaimer at the beginning of each phone call to the point of contact who is being called, who then consents to being recorded by agreeing to provide the inventory via phone. So you may be wondering, why did the project decide to implement a call center, build an application to collect stock data, rather than simply using the staff's cell phones to directly call the facilities? Couldn't we technically have made phone calls and collected data on a spreadsheet, or perhaps even relied on in-country paper-based methods for data collection? The first benefit of using the call center application is the built-in infrastructure that links contacts, records calls, and collects stock inventory information within one unified cloud-based data repository. So this not only limits errors and delays associated with using spreadsheets or relying on paper-based data collection efforts, but it also limits the need for regional travel to confirm data accuracy at these service delivery points, which is especially useful in South Sudan, given the aforementioned security and infrastructure challenges. Additionally, the audio recordings provided through the call center application help to ensure accountability by holding facilities accountable for the data that they do provide. So this, of course, is in addition to the audio recordings, helping us to provide quality assurance internally as well. In addition to these overall benefits of the call center approach, I did want to specify some additional benefits. So for example, the integrated call center also critically provides immediate stock alerts, particularly of stockouts, which are compiled on a regular basis and shared with the relevant authorities and stakeholders, so that we can ensure that the proper intervention is sought and that the issues are addressed appropriately and in a timely manner by the appropriate parties. Additionally, the call center allows for the ability to verify distributions. For example, the GHSC-PSM project in South Sudan hands over family planning kits for distribution in country. So while the project does receive paper waybills to confirm the product arrival from these distributions, the call center actually also helps us to verify these distributions by identifying the spikes in commodity availability every quarter to correspond with the distribution cycle. And finally, the call center also helps to identify stock trends at the facility level, which are then triangulated against other data collection methods to inform data-driven decisions in country. There are, of course, obstacles associated with implementing the call center activity in South Sudan as well. So for instance, our staff have issues reaching facility staff or stock managers who are typically overworked and who are based in facilities which are understaffed. In addition, data gaps and general lack of transparency mean that it is at times difficult to find the responsible supply chain actors for certain actions or tasks necessitated by stockouts and other stock alerts that we identify through the call center. For example, when a stockout is identified, who then should supply and deliver the needed commodities to that facility. Related to this, a high turnover of staff, whether it's within government entities, implementing partners, the facilities themselves, etc., means that the points of contact are always changing, making consistency within the call center's communications and information dissemination difficult. When looking forward and considering the long-term sustainability of the integrated call center application and activity, we expect that the transfer, of the application to the Ministry of Health would be challenging due mainly to the need for ongoing financial support for the maintenance and troubleshooting, as well as general oversight of the application. In this regard, the project would likely need to hand over the application to future implementers instead to ensure continued sustainability of the activity. To this end, the project seeks opportunities where possible to incorporate key stakeholders and Ministry of Health counterparts to ensure buy-in and future sustainability as well. And while data visibility challenges sparked the call center's inception, it has since evolved to become a readily available solution for other country contexts as well, outside of just South Sudan. For example, in Mozambique, a country which already has a robust LMIS system and has already achieved data visibility, we are working on a new component of the call center, which will provide a help desk system to augment and complement the existing sigless LMIS system that is already being implemented in Mozambique. In Niger, the call center is used to regularly collect stock on hand data for malaria commodities from facilities and service delivery points across the country while the nation rolls out its new LMIS system. And finally, the call center in Haiti will be used to verify any GHSC-PSM distributions to service delivery points, verifying that they have been received in accordance with the issued waybills. In summary, the call center is not limited to providing only stock on hand data or being used in contexts where data visibility is lacking. that was indeed the inception of the call center. However, as you can see from the example here, it has evolved into an adaptable tool, an application that can address needs across many countries at different stages of the supply chain, whether that's to enhance an already existing and robust LMIS or to serve as the primary mechanism for collecting stock on hand information. So this concludes my presentation for today. I hope that you have enjoyed learning about our integrated call center activity. As mentioned earlier, myself and Mr. John Stanton, our managing director, look forward to taking your questions now during the Q&A.
Wonderful. Thanks, Sarah, and congratulations. This is a wonderful presentation. Now, I'll ask the judges, perhaps. They may have questions. Pascal?
Yeah, so I had a technical question. I know that you mentioned the stock managers are called on a monthly basis, but is there a specific day and time? I'm interested to know if there's any predictability around that helps the stock managers be able to plan their days and time, particularly at the hospitals is what I'm thinking about most.
Yeah, that's actually an excellent question. So we have had several kind of iterations of trying to figure out the best way to schedule these types of calls. Initially, we did have a kind of a scheduling mechanism where we would call facilities on a predetermined schedule and try to work with them that way. But we found that due to kind of circumstances of the day and what have you, these things change. And so we can't, stringently stick with those timelines and schedules. And so instead, what our team has been doing as of late is kind of informing and working with the facilities on, we will call you around this time of the month, every month to collect the data. And as mentioned before, because of the way that the tool is built, even if they do agree with the hospital or the facility to call at a certain time and that person does happen to not be available, they are able to postpone and call again. So we have kind of tried to think of ways to kind of mitigate any of those like day-to-day shifts that can happen, while at the same time putting together a kind of a way to communicate with the facilities to expect our calls at certain times.
Great. Kelly?
Thanks so much. Very interesting presentation. Really good to see something new and different. I wonder if you could tell us, there were some interesting kind of lessons learned in one of your last few slides. And I wonder if you could just say, if you could do this over again, would you change the implementation in any way? Thanks.
Maybe I can start with answering this question and then hand it over to John Stanton for his perspective, as well, as he was part of the process from the very inception. But I think one lesson learned and something that we may want to do differently in the future is that this call center was put together to try to address the data visibility issues in real time, which meant that we were developing the product, the call center application itself, while attempting to implement it at the same time. So it was very much an iterative process where we were, trying certain things with the application and learning lessons from that and changing it as we go and all of that. So it's very much an iterative process. And I think, that is a lesson learned, and we have a lot of, good examples of how to implement this activity in new countries from now on, based on the South Sudan experience. But at the time, it was something that, had to be, adjusted continually, which, presented challenges in terms of making sure that the data was consistently being collected while we were making those adjustments. But I'll hand it over to John if you have anything to add to that.
Yeah. Hi, Kelly. I would say that I think one of the things that I would not, like if we did this again, I wouldn't underestimate how complicated it is to actually get data. That we probably originally thought that a phone call would be an easy way for people to give us data as compared to like filling out LMIS forms, but it is equally a challenge to get people to give us data. So that's probably something we learned over time. And I'm not sure, we're working on trying to fix that and address it, but it's probably something that we didn't think would be as big a challenge as it actually is.
Well, Stephen, do you have any question?
Yeah, I I think there's a really interesting. So I think the problem that you've been trying to solve and the need for it is actually really clear to me. And I actually want to explore with you a little bit more, maybe like an additional layer of this related to natural language processing, right? So, I mean, in addition to the basic function that you have today, right, which is to sort of say, create, reporting numbers on data that's otherwise hard to sort of get. There's actually a really valuable interaction that happens when you have a human being and another human being talking about the supply chain, right? And so in addition, so I'm interested in the call center interaction today, is there also qualitative information about how things are going? I see that there's like a little comment section that you can probably also capture those things, right? But if there's sort of more like narrative around, on qualitative insights on places, is that something that you can either capture, and then if you're doing, like recordings, can you also then, take transcripts of those recordings, look for patterns, tie them to geographic locations of where certain events or supply chain events are happening, right? Is that something that, that you've thought about, or that you think could be explored further on top of this, in sort of future parts of the solution? Thanks.
Yeah, that is an excellent question. I'm glad that you asked it, and I'm glad that you noticed the comment box. So that is indeed information that we do collect. So every time that our call center agents place a call to those facilities, we ask them to provide us with feedback, first regarding just in general the distribution, deliveries, any stock issues that they are facing, or challenges that they are facing that they would like us to know about, and to then elevate to any appropriate parties. And as we go through the actual line-by-line inventory collection, as you saw, there is a comment box associated with each commodity to allow for us to also collect any information that the facilities wanted to share about that specific commodity. So we do have the ability, and we do have the practice of collecting all of that information. And it is certainly something that we have indeed thought about and looked to the future to, with regards to how to analyze that information collectively. But maybe I'll hand it over to John to talk about that piece specifically.
Yeah, I would just add that I think we're recognizing there's also a psychology of making a phone call that's different than having a paper-based LMIS system or a data driven system in a computer. And I think we're just beginning to see this. And, at this point, we haven't had the opportunity, but we do believe that there's actually an effect when people are communicating verbally, that there's more of a commitment to tell the truth about the data. And again, this is more anecdotally than it is like verified, but it's something we want to look into, but we just haven't had a chance to do it yet. But we definitely recognize that people behave differently when it's a verbal conversation, because it's a personal connection, and it's difficult. When you're filling out an LMIS form on paper, or you're filling it out in a computer, you're removed from that action, and it may take months before the effect of a digit being wrong, or just quickly filling out the form incorrectly because you're trying to get by it. Whereas a call is taking place in real time, and you're committing yourself as a person to that information. So we do believe there's an effect, but we really haven't been able to, to do a proper study, a subjective study on that. But it is something we want to do.
Excellent. Azuka, do you have any question?
I think first of all, anything that talks about technology for real-time data is something of interest for everyone. So well done, Sara and team, for the presentation and the idea to put in a call center. I like the human-to-human contact. My one question would be how, being that we're looking at moving from manual and everybody's looking at automating, and particularly the kind of technology that we're looking at real-time data. And this, from what I hear, is these calls are made once a month, but correct me if I'm wrong. How do we move from the call center to the automation, where we have a technology that can be adopted at the last mile, that everybody is hoping for? Is this something the government is looking at, or are they okay with this with this solution at the moment. So I really want to hear about the government ownership and adoption part of this.
That's a good question. And I think in the case of South Sudan, it's probably, I wouldn't say the wrong country, but it's a challenge in itself that the government is struggling just to keep up with the demands, right? So at this particular moment, we don't see a transition to government owning kind of the solution or being able to move into that role. I think we're learning in other countries, as we've deployed it in Niger, in Haiti, in Mozambique, there's other opportunities where other governments, ministries of health may have an interest. So there may be a better opportunity to implement something like that there. As far as real-time data and other options, we're also developing capabilities to receive calls as well. And, we've looked at having the ability to call into the call center and have a, voice activated system where you could just give the information verbally through technology. Just it would prompt you to give specific data to make it more user-friendly for facilities or users of the system to call in. But at this particular moment, that's not a function we have working. And again, I think we started in South Sudan because of the challenges of the data visibility, the supply chain being fragmented across multiple, donors and implementers across the country, and there was no unified, approach or system. And really, in the near future, it doesn't seem like there's going to be, based on available funding for such a system. So I think our country of choice created additional challenges that we really can't address what you asked.
Ram, you have any question?
One quick question, and that's a little bit off track a bit. Can you explain why there is high turnover? I'm kind of a little bit surprised.
Sure. I think it really depends on which level we're looking at. But in terms of the facilities themselves, I think in general in South Sudan, just the human resource capacity and movement across facilities facilitates movement across the facilities. So we're having some turnover with staff where they're moving from one facility to the next, or just receiving new staff on sporadic basis. But John, I don't know if you can speak to the partners in countries.
I would say one addition to that is that, in terms of the international community that stays in South Sudan, it's almost like a yearly post. So the turnover, even internationally, is so quick. So to try to build some type of consensus for a long-term strategy when people are constantly shifting in and out of the country creates enormous challenges, right? Because you may have an agreement with the UNICEF, coordinator that month, and then 3 months later, that one leaves, a new one comes in. So it's a constant shift of international and local staff. So it creates additional challenges.
Thank you.
Great. We are almost out of time, but there was one question which seems very compelling from Tim in the chat box. You may have seen this. How scalable is this model? That is, how many products do you cover? And is there a limit because it's a manual system? So if you would appreciate a quick response to that before we can switch over to the next talk.
Yeah, I didn't hear all the question, but I would say scalability is related to, I think, like historic experience with the way most of the supply chain projects have been managing over the years, where they end up calling facilities even if they have an LMIS, right? So if you're already using phones to call facilities to get information, to verify data, to check on stockouts, because the LMIS may be slower than you need, or there's errors in the LMIS, it's really just taking the same labor you would have used for that function and kind of converted to a call center. So I think scalability really depends on its use. If you can get people to respond very quickly, the calls could be 3 or 4 minutes, but we have calls that could last 20 minutes because they enter conversations. So I think it really depends. And again, it's a great solution if you already have this process in place and you're already using cell phone networks to make calls, which seems to be pretty common in the work we do.
Wonderful. Thank you so much. Let's give Sarah and the team a big round of applause, virtually, I guess. And up next, let me just pull up, Sarah, if you can stop sharing screen, and you're able to see the screen, right? So adapting routine supply chain supportive supervision to improve healthcare worker capacity.
Greetings to everyone. It is such a pleasure to be part of the 13th
You guys able to hear this?
Here, yes.
Wonderful.
Global Health Supply Chain Summit. My name is Sifundo Zwane. I'm a pharmacist working for the Ministry of Health in the Kingdom of Eswatini as a regional pharmacist. I am with the Global Health Supply Chain PSM Eswatini team and shall be co-presenting on adapting routine supportive supervision to improve healthcare worker capacity and supply chain management performance in the era of COVID-19. I shall be co-presenting on the subject with my colleague, Willie Siduna, who is the Senior Regional Logistics Officer with the PSM Eswatini project. I shall start off by giving a brief background on Eswatini and the health system supply chain in the country. So Eswatini is located in the southern part of Africa. The country has a population of about 1.14 million people and approximately 202,608 people living with HIV. The country is divided into 4 administrative regions, which are Oho, Manzini, Shiselweni, and Lubombo. And the country's healthcare system is made up of hospitals, healthcare centers, clinics, and public health units. And this an ownership of these facilities can either be government, privately owned, or owned by missions. The country has one central depot, central medical stores, which is responsible for housing all health commodities, including COVID-19 commodities for the public sector. Currently, we have 287 facilities that receive their supplies from central medical stores, and 80% of these facilities are clinics. The country's supply chain system is not without challenges. As I've just mentioned, we have one central medical stores that is servicing the entire country or facilities in the country. There's also challenges with supply chain HR across all levels of our supply chain system. Furthermore, there is lack of real-time data, and we have limited end-to-end visibility of our logistics data at the different levels of our supply chain system. To mitigate the challenges in health supply chain, the Ministry of Health, in partnership with the PSM Eswatini project, instituted a supportive supervision approach to strengthen supply chain systems at health facilities in the country. This initiative by the Ministry and PSM saw the appointment of regional logistics officers to support issues of supply chain at a regional level. Through also this initiative, PSM provided support in terms of transport to ensure that regions are able to conduct routine supportive supervisions on a monthly basis. To mitigate the challenges in health supply chain, the Ministry of Health, in partnership with the PSM Eswatini project, instituted a supportive supervision approach to strengthen supply chain systems at health facilities in the country. This initiative by the Ministry and PSM saw the appointment of regional logistics officers to support issues of supply chain at a regional level. Through also this initiative, PSM provided support in terms of transport to ensure that regions are able to conduct routine supportive supervisions on a monthly basis. Our approach to supportive supervision is aimed at monitoring the supply chain performance at facility level. Through these visits, we're able to collect real-time logistic data, which is shared with regional management team and also is shared with the service delivery point for decision-making, and we use this data that we get from the visit to close up on any, to mentor on any supply chain gaps that are vetted. And we may also use the data to avert any stock outs of medical supplies at facility level. Through this supportive supervision approach, the Ministry of Health, with the support of PSM Eswatini, was able to develop an electronic supportive supervision tool that tracks supply chain indicators such as ordering and reporting quality. It tracks also the timelines of logistics management information system reports that are generated by facilities and sent to central medical stores. We are also, through this tool, able to monitor stock management and inventory control for our ART commodities, our TB medicines, our FP commodities, and also on our laboratory commodities. The emergence of COVID-19 pandemic early in the year also saw the use of the supportive supervision approach to include monitoring of COVID-19 commodities as well. I will at this point hand over to my colleague, Willie, who will continue with the remainder of the presentation. I thank you.
Greetings, everyone. My name is Willie Siduna. I'm a Senior Regional Logistics Officer with the GHSC-PSM project here in Eswatini. As mentioned by Sifundo, this approach is data-driven, and we are using a platform called Magpie to collect our data. However, we are in the process of transitioning to serve a CTO, and given the lessons that we have learned during this year, we are also modifying our tool accordingly to gather the data that we might have missed out during the first year. So our results are shared with the regional health management teams, given as feedback to the facilities, and we emphasize sharing of results and information so that supply chain performance is improved. Over the past year, the quality of orders as well as the reporting rates has improved, as shown by this graph, from 64% to 73%. We also had our teams, the regional teams, were quite hands-on in working with the facilities. In some instances, we'll get teams going to facilities to support in arrangement of storerooms, in segregation of stocks, especially where we would find expiries mixed with stock in use. We'd also have our teams going to help facilities label their storerooms. So with the hands-on approach, we also saw the quality of our storage conditions improving over time. And given the fact that we had disruptions due to COVID-19, the visit interval was 6 months. So as we continued with the supportive supervision approach, we had to move with the changes that came with COVID-19. The main one being disruption of supplies due to delays in deliveries. As a result, we had to make sure that whatever stocks were at the facility levels were used to cater for the clients up until the next deliveries came in. Therefore, the advantage which we used was the fact that the regional teams were mobile and had a week per month to go to each region. As a result, as they went out, they would assess the stock status of different commodities, especially ARVs, to ensure that facilities do not run out. And to aid this, a near real-time stock status data collection tool was devised, and it used Google platforms. And we call this tool the Regional Facility Stock Status Monitoring Tool. It's a simple tool which is aimed at collecting information on stock on hand, average monthly consumption, which then gives us the quantity of months of stock at the facility. And in addition to that, we collect information on expiry dates of stocks at the facility level to facilitate redistribution and avoid expiries. So once this data is collected, it's analyzed in Google Sheets. The next slide is going to show you how the regional facility stock status monitoring data collection form looks like. As I said, it's quite a simple tool, which is informed by the central stock status report. So from the central stock status report, we identify products that are stocked out at central level or products that are at risk of stock out at central level. Once these are identified, these become the focal area or the products to be prioritized when monitoring stock status at the facilities as the teams go out to conduct supportive supervision. Let's also bear in mind that it's implementing partners and other staff from Ministry of Health were supplied with the link to this tool so that they could give us information on the stock status at various facilities to facilitate redistribution where necessary and avoid stock outs. Once this data is collected, as I have said, it is analyzed using Google Forms, and this is an example of the output where we have the list of facilities, we have the stock on hand data, we have the average monthly consumption, and then from there we get the months of stock. And it is here that decision making is informed, where as you see facilities with low stock levels or facilities which are stocked out, you look at the facilities with overstocks or higher stock levels and then move stocks from facilities with more stock to facilities with less stock. During the course of the year, we have learned that communication is key, and we also have learned that continued supervision increases confidence in the supply chain, especially by facility staff. As facility staff see regional staff visiting their work areas, they gain confidence in the supply chain. They gain confidence in the fact that someone out there is concerned about their stock status, is concerned about how they are keeping their stock, what they are giving to their clients. So as we continued to visit facilities, we observed improvements in quality of orders and reports, in quality of storage conditions, as well as stock management and inventory quality. The presence of this bridging gap, so to speak, which is the regional teams, saw better coordination and communication between facilities and the CMS. And now the availability of the monthly visits and well-coordinated transport arrangements meant that even distant facilities could be reached out to. This situation previously was not there, as there was lack of resources, both human resources and financial resources. And as visits were being conducted, the redistributed stock was documented systematically, and there was an emphasis on data collection, as I've said. A total of 179 in-person visits were conducted, and 46 of these were repeat visits. And it is these repeat visits, from these repeat visits, that we were able to really see the impact of the activity. And from this activity, 984 patient months worth of antiretrovirals were redistributed between facilities. And this was quite useful given the COVID-19 supply chain disruptions that would have seen other patients not getting their supplies. So this table just lists some of the products that were redistributed during the process. What we have learned from this year is that coordination and communication is key. The fact that there was coordination between the regional level the central level as well as the facility level was a key component in ensuring that sustained supplies are received and there are no stockouts, even against the COVID-19 era where supply chain was disrupted. In addition, the visits increased visibility of the supply chain, and they were able to incorporate real-time stock status monitoring. This tool now is being used to inform quantities of short-dated stock as well as low-moving stock at facilities, given that the stock situation is stabilizing now that the lockdown has eased. As I have said, I'll repeat again that communication and collaboration among the key stakeholders is very important for a robust supply chain. And what I have personally learned, even as we visited, especially the most remote of areas, was the fact that just a visit from the regional staff will increase confidence of frontline healthcare workers, because previously the interval between visits was so long that these people thought there was no level of support from either the region or the central level. But as these visits were rolled out, the confidence in the supply chain increased amongst facility staff. Thank you so much for your time.
Thank you. Wonderful. So I guess, Willie, you'll be taking questions. So let's start perhaps maybe with Sriram.
Thank you very much for a very interesting presentation. I think it's a very challenging environment to work in. So I'm kind of curious as to whether you're, in addition to talking about supply chain issues, are you also offering any courses or training in terms of process improvement or supply chain management to the frontline employees?
Thanks for that question. It's such a good question. Yes, training is a part of what we do. And the basis is usually on the results of the previous visit after identifying gaps and areas which healthcare facilities need support. So after a routine visit to a facility, if you note areas of concern, then we usually book an appointment for a separate visit whereby we train on the areas which need support.
Thank you.
Hello? Hello?
Yes. Who's this? Vincent?
Yes, please. I'm Vincent. I'm talking from Dar es Salaam in Tanzania. I would like to congratulate the efforts that are being done in the Eswatini. So I just wanted to get clarification on whether the LMI system in Eswatini is digitalized, looking at the information that they collected through Magpie, which is mainly done through physical visits. I thought such information would be easily available if the system is digitalized and the support provision that they are conducting would be merely based on the data that is furnished by the reports that the facilities are sending out from their level. That's one. But another thing that I would like to be clear of, what are the data elements that facilities report on their RNRs, the report and the requests, because this information are key. In fact, that they can facilitate decisions at the central level, not depending likely for going down to for the visits. And lastly,
Vincent, if I may interrupt, Vincent, can you just hold off, because we need to also, I'll have Willie respond, but we'll get back if there is time for your question. Just hold that, because we need to get to the judges first. right? So you've
Okay.
asked Willie. So
Thank you.
Willie, do you want to do a quick response now to Vincent's initial questions before we switch to judges? But Vincent, hold off, and I will come back to you.
Okay, thanks, Vincent, for your questions. Yes, the first question, the LMIS currently is paper-based. It's not digital. Eswatini is still in the process of working towards digitalization. I don't know if Tim has something to add to that.
Okay, as you say, Willie, the system is currently being developed to go electronic, but currently we still have the paper-based LMIS. The elements on there are the usual R&R elements: the stock at the beginning of the period, the quantity received, the stock distributed, and the stock on hand at the end. They also calculate the average monthly consumption and then use that to determine the quantity to order. So it's pretty much your classic R&R system. I think the Magpie supportive supervision tool focuses more on the supply chain performance rather than actually collecting the data. It does collect data as well, but the usual data elements still rely upon the LMIS paper-based form. The Google Form platform is more to supplement the monthly R&R form, particularly for specific products that were showing difficulty over the course of the disruptions from COVID. It was developed so that whenever anybody, be they PSM staff or other implementing partner staff, whenever they had the opportunity to visit a facility, to fill out just the stock on hand, the average monthly consumption, and the months of stock for certain products that were posing challenges at that particular time. So it was a way of getting additional information between the monthly LMIS submissions. I hope that answers your question a bit.
Thank you, Tim. Azuka?
Thank you.
Okay, first of all, thank you. The presentation, very, very nice. I think supportive supervision is just one of those classic roles for TA partners. So good to see how you were able to, move from, work with a virtual platform, I think the Google Doc during the lockdown. So, I mean, my not really a question, just to say, because we struggled with this in Nigeria, so I'm just trying to get how you did it. So how did you really manage to get to the challenging places during the lockdown? Were you able to get to everywhere? Were you able to continue your 1 month visit? And how were there challenges to that, or it wasn't really an issue to get to everywhere based on mobility? Or do you think if you could do this another time, you would rather create a more virtual supportive supervision platform? That would be my question.
Thank you. Thank you, Azuka. I think we are quite fortunate in the fact that Eswatini is much, much smaller than Nigeria. So yes, we did have challenges. As you have noticed, the visit interval was 6 months, meaning that we could not reach out to every facility, but we had a level of mobility. So yes, we still had challenges, but we also have the advantage that we are relatively small in terms of size.
Stephen?
Thank you for the presentation. I think I think this project really has all the marks of a very successful, what you would call a successful supply chain project, right? With clear results. And I think the only thing I would ask is, what part of the framing of what you were talking about is in response to, what a supply chain needs to do, in such a, a disruptive event like COVID-19. And I guess my question is, I guess I would have expected to hear something more game-changing, more radical, more like a more ambitious proposal for what to do, given the, if you believe the projections around the impact of COVID-19 on the existing work, how the pandemic actually threatens to undo, has undone or threatens to undo, much of the progress that has been made in global health over the last several years. Is there something bigger, more ambitious that we should be trying to do? And is that something that you encountered over the course of the project that, maybe you could voice a little bit more strongly? Or are there other things that occur to you that we should be doing? Thanks.
Thanks for that question, Steve. It's a good question, and it's an excellent question. Yes, I think for us this was more of a baseline, if I were to put it that way, because as you might have seen, we instituted this systematic approach in November 2019. And speaking of something more bold and more ambitious going forward, I think definitely it would be building upon the gains that we have made so far. And just like as you rightly said, due to the disruptions that we faced because of COVID, we are seeing our facilities becoming more self-reliant and independent, such that now we can move on to more of the virtual platforms in the event that mobility is severely affected. So because the groundwork has been done, the facility staff are now well versed with their LMIS tools. Supportive supervision can be done virtually or remotely. I think as we speak with our current situation, our best move would be to build upon what we have, to stand upon what we have.
Thanks so much, Willie, for your presentation. I was wondering if you could speak to your experience in ensuring that supportive supervision is supportive and is not, that the tone is not fearful or punitive, and it's really used as an opportunity for collaborative continuous improvement. I imagine that that's kind of a risk for these types of interventions, and wondering if you could share some of your wisdom on that.
Thanks, Kelly. As I said in the presentation, that our teams were quite hands-on, which is the approach that we took to really support facilities. So when getting to a facility, the mandate is to assist or aid them in meeting their obligations, is not punitive, or it's not there to audit or to judge. So as I've mentioned in the presentation, that you would find facilities where you have gaps, where you find that their storerooms need to be rearranged. There are gaps in LMIS, in ordering and reporting, and then you would come up with a consultative agreement whereby they have to commit to effecting the changes, but we also have to give a supporting role. So yes, I think the approach currently is very much centered towards being supportive rather than punitive or auditing in a way.
Sara?
A follow-on question to, I guess, Kelly's question. And how much are you directly involving the facility staff in designing your intervention, including the supervision? So it's one thing to say we're trying to be supportive, and it's another thing to say of working with them to figure out what does supportive look like.
Okay, thank you. Thank you for the question. I think our approach is when we assess these facilities, we are assessing them against the standards set by the Ministry of Health, which is the standard operating procedures. If you look at our tool for assessment, it's based on the facility SOPs. We are just assessing adherence to facility SOPs. So as you conduct the assessment during the visits, we are asking them what could be the issues they are facing. What is it that they are encountering, which is, you know, stopping them from being able to meet the set standards. So the approach then is, after we have assessed, you then sit and discuss, and then we find ways of mutually solving these challenges. That's the current approach that we're using.
Okay, thank you. Anybody else from the audience? I think we can spend another minute or two. If you have a question, please unmute yourself and ask. Anybody? Judges, do you have any follow-on questions? No? Well, if not, let's give a big round of applause to both the teams. Thank you so much for a great presentation, and we will call this session a close. So thank you. Take care. All the best. Yeah.